Hello, I'm Dr. Diana Chavkin here at SCRC Fertility. This month is PCOS Awareness Month, and so I want to take a moment to talk about PCOS, Polycystic Ovary Syndrome. I want to talk about how to make the diagnosis, how patients sometimes present to me with PCOS, and how do we treat PCOS in terms of treating patients for their actual health throughout their lives, and how do we treat PCOS specifically when it comes to infertility diagnoses and treatments. So polycystic ovary syndrome is a diagnosis that's made when people present with 2 out of the 3 following situations. So number 1, if somebody has irregular periods. So we know when people ovulate regularly, when they release an egg from their ovary once a month, they'll usually get a period once a month. So when someone comes to me and they say, I'm getting a period once a month, I can say with pretty good certainty that they are ovulating once a month. If they tell me they don't have regular periods, meaning that they don't get a period every month, maybe it's every 2 months, every 3 months. Someone earlier this morning came to see me, told me she gets a period, if she's lucky, every 6 months. What that tells me is that she is not ovulating regularly. She's not ovulating, and therefore she's not getting a period once a month. So the reason why women get regular periods is because when they ovulate, about 12 to 14 days later, they'll get a period. So if the ovulation is not occurring regularly, then the periods won't occur regularly. So that is one of sort of the prime indicators of us to start thinking about polycystic ovary syndrome. I will tell you that polycystic ovary syndrome is the most common reason why women have anovulatory cycles. There are a number of other reasons as well. And so it is very important, therefore, to make sure that people don't have other reasons for the irregular period. So again, when somebody comes to me with irregular periods, I don't just say, oh, you're not ovulating and the most common explanation is PCOS, so there you go, that's your diagnosis. Don't do that, right? Because I need to make sure that there are not other things that are causing the irregular periods, like issues with other hormones like prolactin or thyroid, or maybe they have an extremely low ovarian reserve and are maybe perimenopausal. And so those things need to be evaluated first to confirm that those things are not the reasons why people are having irregular periods. So irregular periods, I think about PCOS, make sure it's not anything else, and then if it's not, we think about other ways to make the diagnosis. So that's one of the criteria. The other criteria are male pattern hormones, and so what that means is either serologically, so meaning in somebody's blood work, we may see somewhat elevated testosterone levels, and then we also sometimes don't see it in the blood, but sometimes people have male pattern hair growth. So where places on the body where women don't traditionally have hair, like on the upper arms or on the chin, or kind of like the sideburns area. So if people have male pattern hair growth there, even if they don't have hormones that are elevated like testosterone, still that can help give them one of the criteria to make the diagnosis of polycystic ovary syndrome. The other criteria are polycystic ovary syndrome appearing ovaries. So that's on an ovary where we see many, many follicles on an ovary. That also clues us into that possible diagnosis. So in order to make that diagnosis, we need 2 out of those 3 criteria. Male pattern hormones, either on the blood or physically, irregular periods indicating anovulation, and then polycystic appearing ovaries on ultrasound. So 2 out of those 3 criteria, and again, excluding anything else that may be causing the irregular periods. And so then the question is, so how do we deal with polycystic ovary syndrome, and what are the issues? Polycystic ovary syndrome is an issue that can cause infertility, and the main reason that it does is if somebody is not ovulating, if somebody's not releasing an egg once a month, well then that egg is not going to be able to meet, then an egg is not going to be able to meet sperm, and then of course a pregnancy won't occur. So when people come to see me, one of my primary jobs is, of course, to figure out why they're not getting a period. If it is polycystic ovary syndrome, think about how we can treat them. And one of the primary ways of treating infertility related to polycystic ovary syndrome is to help to develop follicles, to develop eggs with potentially oral medications like Clomid or Letrozole. We'll do monitoring visits to make sure that the follicles are developing appropriately. And then once we see a dominant follicle, we can actually have a woman's ovulation being induced with a subcutaneous injection like Ovidrel to induce the ovulation. And then we can then say, okay, you can go home and have intercourse, or we can do that in conjunction with an intrauterine insemination. So in the office, we can take either a partner or donor sperm and concentrate that, put that in the uterus, and then increase the chance of pregnancy that way. But again, if the primary reason is about developing a follicle and developing an egg and ovulating, if that's not happening in PCOS, we can make that happen with medications and monitoring. The other thing to think about polycystic ovary syndrome, and too often people kind of miss this, is that polycystic ovary syndrome is not just an issue that leads to infertility. Polycystic ovary syndrome is really an all-encompassing health issue. Polycystic ovary syndrome is often linked to metabolic syndrome, obesity, diabetes, increased risk for cardiovascular issues, and there's a clear link with endometrial hyperplasia and endometrial cancer. So when I see somebody who has polycystic ovary syndrome, I make sure that we talk about these things, because polycystic ovary syndrome is not just this one point in time, let's get you pregnant, okay, and go. I often have a conversation with people to explain you really need to protect your uterus, right? So if you are not ovulating, you're essentially just getting exposed to estrogen. So the way that the ovulatory cycle works, the menstrual cycle works, is at the beginning of the menstrual cycle, so right around the time you get your period, you're getting estrogen exposure from the eggs, from the follicles. In the middle of the cycle, ovulation occurs, and then after ovulation, progesterone is secreted by the ovulated follicle, by the corpus luteum. If you do not ovulate, if you do not have that corpus luteum, what happens is you don't have progesterone production. And then if you don't have progesterone production, your uterine lining is not getting protected, meaning that it keeps getting exposed to estrogen. So it's estrogen effect on the endometrial lining without the protective effect of the progesterone, again, because ovulation had not occurred. Well, then what happens is that the uterine lining is at serious risk for endometrial hyperplasia, which is a precursor of endometrial cancer. And this is the reason why women with polycystic ovary syndrome either need to make sure they're getting a period, every 3 months at least, hopefully ovulating at least once every 3 months. If they're not, then they need to have chronic care with their gynecologist to get either Provera, progesterone, which will protect the uterine lining. It eventually induces a bleed once the Provera stops, but the whole point is not necessarily the bleed. The whole point is the progesterone exposure protecting the lining of the uterus. So that's why when women are in chronic care for PCOS, the gynecologist will say, okay, if you don't get a period in 3 to 4 months, here, take the Provera, will induce a bleed. But again, the key that I think people need to understand is the bleed, who cares? It's the progesterone protective effect that's really crucial. The other thing that women can do with polycystic ovary syndrome is to go on birth control pills. So birth control pills, combined oral contraceptive pills, have estrogen and progesterone in it. The progesterone in there is enough to protect the uterine lining, and so they can just be on that to protect them from endometrial hyperplasia and endometrial cancer. Now, of course, being on birth control pills and also getting a period induced by Provera doesn't make you ovulate, right? In fact, oral contraceptive pills are preventing you from ovulating. And so those are not fertility medications. Those are medications to protect women from endometrial hyperplasia and endometrial cancer. So that's separate. So if somebody comes to see me and they want to get pregnant, we talk about other methods, as I mentioned, something like an oral medication like Clomid, Letrozole, monitoring, Ovidrel to induce ovulation, and then potential insemination or home intercourse. But in addition to that, people, I think, for me, I find that when people come in for infertility related to PCOS, to me, I find that a really good opportunity to counsel people to make sure they understand their menstrual cycle, what's going on in their body, and what the care that they need throughout their lives. Now, as I mentioned, PCOS is also related to other issues like metabolic syndrome, obesity, diabetes, and so women with PCOS, unfortunately, are at higher risk for all of those things. But they're also predisposed in specific ways because women with PCOS often have a hard time losing weight. and the weight that they carry puts them at higher risk for developing the symptoms related to PCOS. So it's kind of like this vicious circle. I often recommend that women with PCOS see a nutritionist sooner rather than later to talk about different diet modifications, things like high protein, low carb, complex carbohydrates, all of those things that are low in glycemic index, low in straight sugar, will give them a better chance at regulating their sugars, put them at lower risk for diabetes, lower risk for metabolic syndrome. And then I often do find that women who have their diets controlled and lose weight in these ways will also have sometimes their periods come back. So again, sometimes the symptoms of PCOS are put at bay when a woman's weight is better controlled. And the reverse is true as well. When the weight increases, the symptoms of PCOS can be exacerbated. Okay, so that's sort of the spiel on PCOS, Polycystic Ovary Syndrome. And I hope, with this month being PCOS Awareness Month, I'm really hoping that people are more and more aware of PCOS. I'm hoping that people come and talk to their physicians and they get the care that they need, and that they realize that it's an all-encompassing health issue, not just a fertility issue. Somebody has a question, and feel free to send in your questions, and you can do that now, or you can also feel free to reach out. I think there's a link here on this, on the text of this, and you can feel free to reach out, make an appointment, and ask your questions, but I'm also happy to answer some questions now. So what could be a reason for extreme painful periods? So usually not necessarily related to polycystic ovary syndrome, but painful periods is more something we think about related to endometriosis. So endometriosis is a disease where the cells that line the inside of the uterus somehow implant outside of the uterus in the abdominal peritoneal cavity. And the concern when that happens is that it can trigger pain, and for a lot of women, very, very severe pain. So that is probably one of the most common reasons. There are many other issues as well relating to scar tissue, dyspareunia, which is also pain related to the vagina and related to intercourse, and also can be related to painful periods. Any other questions I can answer? I mentioned with polycystic ovary syndrome, right, some of the first-line treatments are things like oral medication like Clomid, letrozole, and then potential insemination. We can also offer things like IVF to patients with polycystic ovary syndrome as well. It depends on what their family goals are, what their ovarian reserve is, and sort of how old they are in terms of thinking about what treatments to offer. So here's a question: how long would you recommend someone wait with PCOS to conceive naturally before trying medication to induce ovulation? Okay, so very, very good question. I mean, the bottom line is, how severe is the polycystic ovary syndrome? So let's just be clear. Somebody said, okay, if I have PCOS, how long should I try before trying a medication to induce ovulation? So let's say somebody's trying to conceive for 2 to 3 months, but they know in their history they don't get a period, ever, or they get a period once every 6 months. I mean, I would say in that situation, there's really no point in having a woman wait for multiple months. I mean, the way that we make the diagnosis of infertility is we say, if you're less than 35 and you've been trying for a year, you have a diagnosis of infertility, and so at that point you want to get going, sooner rather than later to be evaluated into a position for potential treatment. Over the age of 35, because age becomes a very, very serious issue at that point, you don't want to wait more than 6 months. Okay, so someone with polycystic ovary syndrome, how long should they wait? I don't think those same time criteria fit women with polycystic ovary syndrome who don't have regular periods, because we know if you're not getting a regular period and you're not ovulating, you're not going to get pregnant on your own. And so I would say, even if you have a history of knowing you don't get a period for many, many months, and I would say you probably shouldn't waste too much time, if any, trying to conceive on your own, because if you're not ovulating, it's not going to happen. If you have PCOS and you do get a period, once a month, I would say your PCOS is pretty controlled, and so you may want to fall more into that that criteria of, okay, 6 or 12 months of trying, again, making sure that everything else is normal. So you want to make sure that there's nothing that's standing out as a potential issue that needs to be addressed. You're welcome for answering. We answered that question. What's the best? So Clomid or letrozole, right? So I mentioned both. So again, these are oral medications that help to induce the follicles, to help to induce the egg to develop. And again, with PCOS, the follicles and the eggs are not getting recruited. They're not developing. They're not ovulating. Clomid has traditionally been sort of the more standard of care treatment. It has more data and more history to it. So I would say Clomid is usually first line. Letrozole is great and is used as well. There's sort of pros and cons to both. I usually say, Clomid is sort of the one you start with, and if you don't have a great outcome, if you don't love the side effects, potentially we can do letrozole. Clomid is nice because when you use Clomid, you can actually monitor estrogen levels as you're developing in your cycle. With letrozole, it's a little trickier. So when you take letrozole, the estrogen is a bit lower, so you have to go based on the follicle sizes. So it's a little trickier. I mean, they're both good, and they really work very, very similarly, and that what happens is with Clomid, the brain thinks there's no estrogen, so then the brain secretes gonadotropins, FSH and LH, to stimulate the ovaries to develop follicles. Letrozole works in a similar way, but instead of tricking the brain to think that it doesn't see the estrogen, it actually decreases the circulating estrogen. So either way, the brain doesn't see estrogen, and so then the brain is tricked into producing FSH and LH, which then stimulates the follicles to develop. So they both work in quite similar ways, and people respond differently to either. I've tried IVF and failed. So in terms of, IVF cycles, I mean, this is kind of a question relating to having tried IVF and having very painful periods, and it sounds like long-term infertility. I mean, this is definitely, I'm happy to address in sort of a longer, more extensive conversation. I would say this is not a unique story, unfortunately. I think that this definitely requires having a physician really take everything into account, put it all together, and kind of treating it, with incredible thoroughness to make sure that all these things are addressed. But I'm obviously sorry to hear that that's happening for you. Painful periods potentially related to endometriosis. I'd want to make sure that the fallopian tubes are open. Potentially endometriosis can cause scarring of fallopian tubes, and if the tubes are blocked, the egg and the sperm are not going to meet. Endometriosis can also affect ovarian reserve, and if ovarian reserve is low and the egg counts and the egg quality are not good, that could affect fertility. So that's potentially an issue. Someone says if you took Clomid but progesterone still doesn't go up. I think maybe so essentially progesterone will elevate after ovulation. So it sounds like potentially if you took Clomid and then maybe you didn't ovulate, you're not going to see the elevated progesterone. So then the question becomes, okay, if I took Clomid and why wouldn't I have ovulated? So again, with PCOS, I don't just recommend Clomid. I would want to do Clomid while doing ultrasound and blood work and monitoring very carefully, because you can't say, okay, take Clomid, see if you get pregnant. You have to take the Clomid and you have to see if you respond to the Clomid. There could be a number of reasons why progesterone didn't go up. Potentially you didn't ovulate. Potentially the Clomid didn't work to develop a follicle. So Clomid and letrozole don't always work to recruit follicles. And so, I really think when you're taking these medications, you have to be monitored closely with ultrasound and blood work to see what's going on, because the end result is not just, okay, did I get pregnant or did I not, right? You have to know if the Clomid even worked to recruit follicles, because if it didn't, you don't want to keep taking the same thing. Clomid can have side effects. So Clomid, it tells the brain that there is an estrogen, and so the brain essentially thinks it's in menopause. And so women on Clomid, potentially have hot flashes, night sweats. It's not the funnest medication to be on, and so you want to make sure that if you're taking it for a good reason. And so, I would say if the progesterone didn't go up, potentially you didn't ovulate. And how do you know if you don't get careful blood work and ultrasounds? You'd want to do that very carefully. And if the Clomid's not working, even sometimes you need a higher dose of Clomid. Sometimes switch off to letrozole. If it's not working at all, you think about IVF sooner rather than later. Is there a time limit for frozen eggs to be used? So the answer to that is, so the eggs, when they're frozen, there's a specific chance of those resulting in a pregnancy based on your age and based on the number of eggs that you froze and based on the quality. And that percentage, that estimation, is stuck in time. So whether those eggs are going to result in a pregnancy down the road is going to be the same whether you use them a year after you freeze the eggs or 10 years after you freeze the eggs. So that's important to know. So no, there's no expiration date on the eggs. The only thing I will say about that, though, is that if, let's say you freeze eggs and you say, okay, I'm not going to use them for 20 years because my chances are locked in. What you have to realize is that the eggs in your body are undergoing changes. The eggs in your body are less likely to result in a pregnancy. And so if, let's say, you froze a number of eggs and then you waited 10, 20 years to use those eggs and those frozen eggs didn't result in a pregnancy, your backup plan, which potentially is the eggs in your ovary, are now that much older. So that's the only thing I would say about timing when you're waiting to use those frozen eggs, is that if you're going to back up plan to your natural eggs, your eggs in your body are definitely going to undergo changes over time. I mean, I know that's kind of maybe an obvious thing, but just I think it's an important point that people, really grasp. But again, bottom line is eggs frozen, embryos frozen. As far as we know, there's no expiration date and there's no degeneration in quality or quantity as they're frozen over time. Is there an optimal time period to use them in? I mean, again, as I mentioned, our backup plan is always sort of our natural, right? So let's say you use the eggs, you get no embryos, it's like, okay, well, maybe I'll use my eggs that I have now. Those eggs will degenerate in quality over time. So it's always kind of like, the sooner, the better you figure things out, the better. And frozen eggs, frozen embryos, same thing. So they don't expire over time, as far as we know. And you are welcome. Let's see, any other? I think I answered all the questions. Thank you all for joining today. Here's a good one. Can you get pregnant from IVF after you have started perimenopause? Yeah, that's a great question. After you have stopped regularly getting your period. So yes, in fact, you can. So this is one of the beauties of having eggs frozen, having embryos frozen. So once they are frozen, and we can test the embryo and know if we know that the embryo is chromosomally normal, meaning 46XX or 46XY, then the chance of pregnancy when we take that embryo thawed and put into a woman's uterus, the chance of pregnancy is about 60-70%. And that is whether she ovulates on her own or doesn't. So a woman could be, we have some women who unfortunately are perimenopausal, menopausal at, 40, 45. And even for those women, we can have them take estrogen and progesterone to support the lining and then put the embryo in the uterus, and the chance of pregnancy is the same, 60-70%. The concern with getting older is not really about the success of the pregnancy. So if the embryo is the issue with getting older is that the age of the eggs, right? So as the eggs get older, the eggs are less likely to be chromosomally normal, and if they're not chromosomally normal, the resulting embryo is not going to be chromosomally normal. Hence the reason for freezing eggs, freezing embryos at a younger age. If you have an embryo or an egg, right, that's chromosomally normal at a younger age and you use it at an older age, the chance of pregnancy is 60-70%. And that's whether you use it at age 40, 45, right, 48, 49. So just to make that clear, I will say, though, that as people age, things happen, right? So as we get older, we may develop heart disease or lung disease or blood pressure issues that make it more complicated to be pregnant. So there's higher risk of preeclampsia, gestational diabetes, like lots of complications as women get older. But the success of the pregnancy really depends on the chromosomes in the embryo. And as long as a woman has a uterus, whether she's ovulating or not, or menopausal or not, we can get her pregnant. And related to those issues that develop as we age, when we have a woman who's 45 and older, we'll always have her have a conversation with a maternal fetal medicine physician and have an evaluation to make sure that she is healthy enough to carry a pregnancy. And of course, all the risks will be reviewed as well in advance. So the indication for PCOS, as I mentioned when we started, so to make the diagnosis of polycystic ovary syndrome, you need 2 out of 3 criteria. One would be irregular periods or some evidence of anovulation. The other would be polycystic ovary syndrome, or polycystic appearing ovaries on ultrasound, so basically many, many follicles. And then the other one is male pattern hormones, either serologically on a blood test or just male pattern hair growth or acne or baldness or male pattern baldness that would make us think that there are elevated androgens or more elevated than you'd expect for the average woman. Okay, well, with that, I will sign off Polycystic Ovary Syndrome Awareness Month. Thank you for checking in. Please feel free to reach out to our clinic. Love to speak with you guys live. Thank you and have a beautiful day.